this topic, which is new emergence of new therapies in field of asthma. So we heard the previous speakers and a lot of talk about innovation. So whenever a new molecule is being developed, a lot of investment of resources happens from the industry to develop the new molecule and also to find out its exact role in our treatment, in the management protocol. So many a times it so happens like this new molecule, biologics, which are now available in India, but many of our patients, it is still out of reach for them. But also one good thing that happens that resources get invested in understanding the pathophysiology of the disease. So we end up getting a new vision to look at the same old disease. So many of our patients may not actually be using this biologic, but the understanding of pathophysiology and the factors that lead to severe asthma, that understanding actually helps us to better manage all our asthma patients. So it's a challenge to cover this topic in 20 minutes, but what I'm going to do is make you understand where exactly would be the role of biologics into the management of asthma. So we all must have some goals for our asthma patients together, and we should be monitoring and reviewing the goals. So what I'm going to cover over next 20 minutes is identify severe asthma patient, identify and address all the risk factors that leads to uncontrolled asthma, and therapeutic goal setting, making the patients aware of those goals and reviewing and reassessing these goals periodically, algorithms to manage difficult asthma, and once you understand that your patient is severely asthmatic, then you need to understand the pathophysiology to phenotyping and endotyping before you actually use the biologics. So what exactly is the role of biologics and evidence and real life experience of biologic in severe asthma. So how common is severe asthma? In fact, 91% of the asthmatic perceive wrongly that their asthma is well controlled, and this must be experienced with all of us. Many of our asthmatic patients for years together, they do not follow up, they do not even monitor their parameters, and they are in the false sense of security. This is a Asia Pacific study which included Indian patients also. 66% of patients experience exacerbation every year, and they accept this exacerbation. The doctors and the patient themselves accept this exacerbation. 42% make frequent emergency visits, and 64% of the patients use incorrect inhaler technique, and that is one of the key reasons for having uncontrolled asthma. So what should be the goals of your asthma treatment? And this is very important. When you initially start your asthma patients on treatment, you should have very clearly defined goals and which you should be sharing with the patient, so the patient is also aware what to expect. So symptom control is one of the major things. Second is patient should be able to enjoy near normal activities. So unrestricted activity or unrestricted life, good health related quality of life, and preventing the lung function decline, which is very important. And for this, you must be periodically monitoring and advising your patient to undergo spirometry. Then preventing exacerbation and hospitalization, and that is one of the key factors which actually leads to further worsening of the lung function, and prevention of treatment-related adverse drug reaction. So what is uncontrolled asthma? So uncontrolled asthma is defined as any one of the following, that is poor symptom control, frequent severe exacerbation, serious exacerbation requiring hospitalization or ICU admission, airflow limitation, and controlled asthma that worsens upon tapering the high dose of inhaled corticosteroid or systemic corticosteroid. So patient is maintained and symptoms are not there, but the moment you taper down from high corticosteroid to low, medium dose corticosteroid, the patient symptoms are worsening, then this is classified as uncontrolled asthma. But are all uncontrolled asthma classified as severe asthma? No. So uncontrolled asthma, as we have seen, poor symptom, frequent exacerbation, serious exacerbation, and limitation of the worsening of the lung function, and requiring high dose inhaled corticosteroid and long acting beta agonist, and systemic corticosteroid for more than 50% of the days in the previous year. But there are so many factors of these uncontrolled asthma which you may be actually able to address. So you may have to actually reconsider the asthma diagnosis. Sometimes patient is wrongly labeled as asthma. There are many mimics, Then contributing factors, most important are adherence, inhaler technique. You'll be amazed to see if you start to check inhaler techniques of your patient in the OPD, more than 50% of the patients are actually using wrong inhaler techniques, and many a times we get a feedback that physicians have been so busy in their practices that they do not have time to teach their patient the inhaler techniques. Trigger exposure is extremely common, and presence of comorbidity. So when you identify and address all these issues, say maybe about 4 to 5% of your patients who are uncontrolled asthma would actually be having severe asthma. So 90-95% of the patient you can address all those issues and they may not be actually severe asthma. So many times if this detailed evaluation is not done, patient is referred for biologic and you have so many unaddressed conditions and you put these patients on biologic, give them expensive therapy without addressing the other issue, the patient is going to be very unhappy. So how do you monitor your patient? You must have a monitoring plan. So at a physician level, at your level, you must be advising your patient to have regular follow-up visits in which you will be asking about the symptoms. Every visit, inhaler techniques and compliance should be checked. Ask actively about triggers and exposure. Treatment-related adverse drug reactions have to be asked. Sometimes you need to investigate also. Asthma control test is widely available, freely available on Google. You can download this and you can ask patients asthma control test. Monitoring the inflammation. So how do you monitor the inflammation? So commonly we do blood eosinophils. When the eosinophil levels are more than 300, it means active ongoing inflammation is there. IgE levels, that will tell you about the atopic inflammation. Exhale nitric oxide. Sputum eosinophils are much more specific but it's not very easily available. Then patients should also be involved in their monitoring. So self-monitoring with help of home PFR, symptom diary triggers are very important. And you monitor the lung function with spirometry, PFR and 6-minute walk test. Okay. So how do you manage your patient? The stepwise approach of GINA guidelines, the new updated guidelines 2021. So step 1 and step 2 is patient who has got intermittent asthma or mild persistent asthma, which means symptoms are either less than 2 times in a week or more than 2 times in a week but not daily. So symptoms, day symptom, night awakening, use of rescue inhalers, if it's there either less than 2 times or more than 2 times but not daily, then you can manage your patient with low dose inhaled corticosteroid. If symptoms are more persistent, that is more than 2 times in a week or almost present daily or having 1 or 2 exacerbation, then you step up to the higher step that you give low dose ICS along with LABA. If patient remains still persistently symptomatic, which is classified as moderate persistent asthma, then you have to go on for medium dose inhaled corticosteroid. And patients are not doing well on any of this, then these patients are considered as severe asthma. Then you have to put them on add-on therapy, which means high dose inhaled corticosteroid with long-acting beta agonist. You may have to add tiotropium, you may have to add oral corticosteroid, and these are the patients who are the candidates for biologics. And you must always monitor your patients for ADR related to oral corticosteroid. In fact, that was one of the most important reasons why the biologics were developed, because we all know all patients who take long-term oral corticosteroid have multiple side effects, and the commonest is osteoporosis and dyspeptic disorder, and you must monitor your patient for this side effect. So 93% of the patients with severe asthma have at least one OCS related adverse effect. So now let's understand how we can investigate our patients of severe asthma. Which is this case discussion. A 51-year-old female diagnosed with asthma for 10 years, presented in June 21 with worsening symptoms for 2 weeks, dry cough and dyspnea on exertion grade 2 to 3. Last several exacerbations for last 2 years, 1 hospitalization. She's already on maximum therapy, that's step 5, high dose inhaled corticosteroid, LABA, LAMA, Montelukast and oral corticosteroid. So is she a case of severe asthma? How many would say that this is a case of severe asthma? Okay, only 1. How many say it is not severe asthma?
Can you reveal any findings? Any investigation findings?
Okay, yeah. So, further taking the history, she had chronic rhinosinusitis, was taking inhalers without spacer, regular dusting at home, defaulted on inhalers several times. There was a recent weight gain, 8 kg, uncontrolled diabetes, depression after losing her husband, GERD. Now, is this a difficult asthma or severe asthma?
Difficult asthma.
Okay, good. So, pulmonary function test showed that she had severe obstruction, irreversible obstruction. So, already remodeling had happened. Asthma control test, any score below 19 is uncontrolled. So, she was 16, 2D echo normal, HRCT normal, IgE was high, absolute eosinophil count more than 1000 cells per ml. And after addressing all the risk factors, there was moderate improvement in her symptoms. So how do you evaluate difficult to treat asthma? Diagnose, first confirm the diagnosis. Diagnosing a difficult asthma, confirm the diagnosis, look for contributing factor, optimize the management, which is already done in her case, review the response after 3 to 6 months, and even after that if patient is not responding, then this patient qualifies for considering biological in the management. So let's understand this algorithm. Symptoms, this patient had cough, wheezing, breathlessness, already on high dose inhaled therapy. Now this could be either because asthmatic patient has some other unaddressed condition, or it may be non-respiratory issues like GERD, anxiety, dysfunctional breathing, deconditioning, overweight, and as you can see our patient had many of these things. Now if you rule this out, then look at symptoms due to asthma. Then check for adherence and inhaler technique. If is it because of airway inflammation or is it because of airflow obstruction. And if airflow obstruction is normal, your inflammatory markers are normal, then you have to look at the other causes for asthma. And in our patient, she did have high eosinophil count, she did have high Ig levels, so she does qualify for biological therapy. If you look here, you will understand she has all the three components. She has a lot of comorbidity, she also has undergone severe obstruction, and she has high inflammation. Now if you just concentrate biologics and don't look at the other two factors, the patient is not going to be having optimal effect. So you have to address all the three components. So let's understand now how do you phenotype and endotype your patient. So when you investigate the patients and find out, so these can be classified into different types. Severe allergic phenotype, early onset asthma, history of atopy, history of rhinosinusitis. These are the patients who have high Ig levels, and in these patients, anti-Ig molecule omalizumab would be the right choice. The patient who have severe eosinophilic phenotype, they will have high inhaled nitric oxide, they will have high eosinophil level, the peripheral or sputum eosinophil levels, and these patients would be right candidate for anti-IL-5 molecules like mepolizumab or benralizumab. Patients who have severe asthma with remodeling, these are the ones who will not do very well on biologics, and these patients should have tiotropium, long-acting beta agonist, bronchial thermoplasty. They should also be given pulmonary rehabilitation. And severe neutrophilic phenotypes where you have to treat them with macrolide. So it's extremely important that you phenotype and endotype your patient to be able to understand which patients are going to do well and which biologics. Okay? So what are the biologics which are approved in India? Omalizumab, it can be used in moderate and severe persistent asthma beyond the age of 6 years. What is the dose? The dose actually depends on the weight of the patient and the Ig levels. So 75 to 375 milligrams subcut you can give. The dosage frequency is 2 to 4 weeks, and severe side effects are anaphylaxis, injection site reaction. So at a time, not more than 150 milligram is given at one single site. Mepolizumab is anti-IL-5. This is used beyond the age of 12 years. 100 milligram subcut is the dose. The dosage frequency is 4 weekly. It does not depend on the weight or the eosinophil levels. And benralizumab is again an anti-IL-5, but it is a receptor antibody. So it is supposed to have much more profound effect because it blocks the anti-IL-5 receptors. 30 milligram subcut. Another advantage of benralizumab is that first 3 doses you have to give 4 weekly, and then subsequent doses is once in 2 months. So which means many a times we talk to the patient who've been chronically on this treatment, And once you start the biologic, at least for 2 years you have to give the biologic. So every 15 days if the patient has to come and get hospitalized, they will not be very happy with this kind of quality of life. So in that sense, benralizumab does have advantage in eosinophilic asthma. So how does this work? The two molecules, which is mepolizumab and benralizumab. So mepolizumab is anti-IL-5, which attaches to the IL-5 cytokines, and then there is destruction of the IL-5 antibodies. But sometimes there are multiple pathways and some of the pathways may be missed, so the treatment or the response may be suboptimal. The mechanism of action of benralizumab is that it attaches to the alpha receptor, IL-5 receptor, and once attached to this receptor which are there on eosinophils and basophils, that gets attacked by the natural killer cells and there is a cytolysis. So it has much more profound effect on the eosinophilia. So it induces rapid and near complete depletion of eosinophils. So one of the phase 1 trial which was initially conducted, it was found that it leads to zero blood eosinophils in the patients if they are evaluated bone marrow, sputum, blood eosinophils, and all the levels, the reduction in the eosinophil count was much higher and 96% depletion was found. And benralizumab aims for zero exacerbation over a period of time. So there are multiple trials were conducted and these patients in the initial trials were continued in the subsequent trials. So they had data of reduction in exacerbation year 1, year 2 and over year 5. So in first year it was found a sustained reduction in the exacerbation in 63% of the patient. In year 2, 74% of the patient, and year 5, 87% of the patient had zero exacerbation. So I've been talking to my colleagues who've been regularly using the molecules, the biologic, and very few biologics have actually found that they improve the lung functions. And so benralizumab studies have claimed that it actually improves the lung function, but we've yet to see, because this is new molecule now, we've not used so many numbers, so we've yet to see that actually whether it improves the lung function. But even if we are able to prevent the decline in the lung function, prevent the frequent exacerbation, that is also good enough. And it's all also boils down to how early in the treatment you pick up these severe asthma cases and how early you initiate them on the biologics. If you pick them up early, before the lung function decline has happened, then this patient would do much better. So again, the zero exacerbation is what is being aimed. There is no end-to-end comparison studies between different biologics. Only one study where omalizumab patient did not do well and they were put on mepolizumab and there was almost 30% reduction in exacerbation. But between the similar molecule, that is mepolizumab and benralizumab, there are no end-to-end studies, but different studies have been compared. Like in benralizumab, phase 3, 28-week randomized control trial in oral corticosteroid dependent severe asthma, and there was median reduction in the median reduction from baseline of 75%. That was reduction in the steroid dose. And just 2 more minutes. While in mepolizumab, the median reduction in the oral corticosteroid dose was 50%. So when we evaluate our patients for considering the biologic, there is a systematic evaluation, and in fact all of you may not be using the biologic, but if you screen your patient, at least you will understand that which of your patient may actually need biologics. So this is a form, and this is also available. I think Astra counter is there outside, and any of you who have been having asthma practice, you can pick up this form and actually evaluate in patient in a stepwise manner. So any of your uncontrolled asthma patient, you rule out the other factors, the reversible factors, and you think this patient may be severe asthma, then you follow this stepwise proforma, reconfirm the diagnosis, check adherence to prescribed therapy, rule out other causes and comorbidities, and confirm that this is a case of severe asthma. Then go for biomarkers, phenotyping and endotyping. Evaluate your patient for appropriate biologic, and then you can refer for a specialized center And then once the patient is put on the therapy, periodic evaluation, usually after starting biologics, 4 to 6 months later has to be done. So we do have a severe asthma program at Jupiter Hospital, and so any of you who can rightly select your patient for severe asthma can refer the patient. So just to end with last 2 slides, the take-home message is goal setting and regular monitoring are the most important steps in management of asthma. You must be asking spirometry or regular PFR monitoring for your patient. If your patient is not doing well, at least 3 to 6 months spirometry, the patient is doing well. Then once in a year or 2 years, you must look at the spirometry of the patient. When the patient is not doing well, reconfirm the diagnosis, identify and address all the risk factors in uncontrolled asthma to actually screen out the right candidates having severe asthma. Phenotyping and endotyping is very crucial, and at your level also blood eosinophil or IgE levels can be done, and you can phenotype or endotype your patient. T helper cell response, that is mediated through either IgE or eosinophil. And these are the patients these are the inflammation can be targeted through biologic. Omalizumab for atopic asthma, mepolizumab and benralizumab for eosinophilic asthma are emerging biologic. They're driving the precision medicine for severe asthma. So thank you all for patient hearing.